We are back on the Zero Hour. I'm your host, Richard RJ Eskow. People with diabetes in this country have been subjected to a horror show of greed over insulin prices. We've covered that to a certain extent on this program. My next guest has been writing about some of the claims being made by Democrats about this issue. I always look forward to reading her work. I get a lot out of it. I'm glad she's out there. She hasn't been on the program for a while, so I'm also glad she's back. Natalie Shure is a writer and researcher based in Boston whose work focuses on history, health, and politics, and she joins us now. So first of all, Natalie Shure, thanks for coming back on the program.
Thanks so much for having me. It's great to be back.
It's great to have you back. And let's start with this. Well, if you would just summarize for us, Build Back Better and insulin. Are Democrats overselling what they're going to do here?
Yeah. So, starting right after the House passed the Build Back Better bill, which of course has to still go through the Senate, so it might undergo further changes before landing on Biden's desk. But right away, a lot of not only House members, but Senate members looking to promote the bill before that period happens were saying things like, we've capped insulin at $35. No one will pay more than $35 for insulin moving forward. What is really in the bill is a copay cap of $35, which at the federal level will help a lot of people. That's going to improve prospects for a lot of patients, but doesn't apply to uninsured people and won't apply to the many gaps within our healthcare system that are very easy to fall in if you're a type 1 diabetic or an insulin user. So I think it's very important to understand the difference between those things and understand the significance of a price cap versus a copay cap.
And I want to talk about how, the suffering and the challenges of being a person who depends on insulin. Before we get there, Natalie, if you don't mind, just looking at it, this is something that's bothered me for a while. The pharma industry has often proposed what I'll put in air quotes reforms that involve limiting the copays that people pay for drugs. But on the macro level, there's still this enormous wealth transfer going on, isn't there? I mean, to me, it's good from a human point of view if some people, we can talk about the gaps, but some people only have to pay $35 for their insulin. But if society as a whole is paying thousands of dollars a year for, of course, and some of our audience will know, for a medication that was essentially given away by its discoverers in 1923 for $1 a piece, that was $3 total, that there's still a wealth drain being taken from the public and forced into the bulging pockets of the pharmaceutical industry, don't you? I mean, obviously this is a loaded question, but don't you think?
Yeah, I mean, certainly, if no individual patient pays out of pocket, we would still be paying collectively the way that we do for many other drugs. That'll still be true in a Medicare for all system as well, that there will be, a lot of government payment for these things. And that, at some point, we are all paying for that public money. That's how it works. I think that's preferable to the situation we find ourselves in now. When public payers are putting up so many resources for these drugs, they ought to have some control over how much they cost, as opposed to giving drug manufacturers unilateral power to set those prices. So I fully agree with you that they are setting those prices too high. That would be true whether the government was fully paying for these things or not. But it would certainly be nicer to have some more control over how much that sum happens to be.
Yeah, well said, better said than I did. Now, what about this cap on prices, you're making the point that some people enjoy this, but many people will not. What's that about?
Yeah. So one thing when I'm talking about cracks, I think that it helps to understand, type 1 diabetes. So most of the people who, or not most, pretty much any type 1 diabetic is insulin dependent, along with many type 2 diabetics. Often when we're talking about insulin users, we're talking about, type 1 specific issues. We're talking about short acting insulin. So just to put that out there. If you are someone with type 1 diabetes who uses short acting insulin, that basically means that you have to constantly manage the condition. It means that, you have to basically do the work of a pancreas. We all produce natural insulin, but type 1 diabetics have to take insulin that they're prescribed. And it's a very constant process throughout the day for a lot of people. I've heard patients describe it as, basically doing a math problem in the back of their head at all times. And I think more importantly, it's something where if you don't have insulin in as short as a couple hours, you can be, facing a medical emergency. So when you think about it, there really aren't that many drugs like that in the world, right? There aren't too many situations. Of course, there are so many drugs that people need to live. It's not as if people who take insulin are more important or more valuable than other people, but there are not many drugs where if you're apart from it for just a couple hours in one day, that can be a catastrophe. So what that means is that those people are very uniquely vulnerable to the many gaps in our healthcare system. Right off the bat, we know that around 10% of Americans, give or take, are uninsured. So that's about 30 million uninsured people. Certainly plenty of those people at any given time do use insulin. But there are also other gaps. There are things like, people who spend a certain amount of time between insurance plans, waiting for a new one to start. Someone who's just started a new job and their insurance hasn't kicked in yet. Someone who, has a network in a given state and realizes that they left their insulin at home, needs to refill in another state or another town where they might not necessarily have a network. So there are all sorts of little ways to find yourself in a situation where you do have to pay full freight. Even among insured people, so many people that I've talked to have had some situation like that. Even if you drop your vial of insulin, it shatters. You have to get another one, and you've already used your insurance allotment for the month. There are just so many little ways to be screwed over in our healthcare system. And when you are on a medication that even just a couple hours away from it can be the difference between being healthy and being hospitalized, that's a huge deal. Those gaps, of course, come up for other people, but they might not necessarily experience it as an emergency. I think that we've all had situations where your prior authorization didn't go through with your insurer, so you might wait to pick up a medication until Monday as opposed to Friday. Things along those lines, waiting for the authorization to go through so that you can get your insurer to pay for it instead of paying for it out of pocket. A lot of us have done things like that, but it hits a bit differently, and we're not quite as vulnerable in most cases to the difference between waiting a couple hours or a couple days. So the fact that insulin is so necessary on such a constant basis and the list price is so expensive means that people who need it every day for the rest of their lives really face a lot of difficulties because of that. So I know that's a long answer, but I think it's important to understand all of those dynamics.
No, it's really important. Again, we're talking to Natalie Shure about her article in the New Republic on insulin. And I think, one of the great points you make, tragic but important, is we covered the death on this program of Alec Smith, other people who have died because they couldn't get access to insulin in time or tried to ration and stretch their insulin and died as a result. And one of the points you make is that most or all of the people who have died because they couldn't get their insulin were uninsured and therefore would not have been saved. And correct me if I'm wrong, but my understanding from your piece is most of those people that have tragically died because of our insulin policies would not be saved by what the Democrats are doing. Is that correct?
So it is true that Alex Smith, along with several other people who have died rationing their insulin, were uninsured. And so, strictly speaking, a copay cap does not help uninsured people. What it might do is for people who can only afford a high deductible insurance plan. Before, if you're paying several $100s for a high deductible plan and then know that you'll need to spend a few months paying full freight until you hit the deductible, for those people, it made rational sense perhaps to go for a stretch without insurance. This does somewhat change that calculus, because even if you're paying a few $100s for a health insurance plan, if there is a copay cap, that also applies to deductibles. So if you have a high deductible, even if you haven't paid it down yet, the copay cap does apply. Now, it also means that you won't hit your deductible as quickly. So ultimately, it doesn't necessarily mean that you will be spending less money given the cost of insulin supplies or any other health services or drugs you might be on. But it does mean that you won't have a $300 obstacle when you desperately need another vial of insulin. So all of that is to say, it potentially changes the landscape for certain uninsured people, depending on specifics. But we just know that in our country, millions and millions and millions of people are uninsured at any given time. There are countless ways to fall into a gap here and there. And so, whether or not this does change the landscape and make insurance a better deal for people who are diabetic, we just know numerically that there are going to be people that are affected by the list price of insulin. And there are going to be people who need this to be a more seamless and universal system design.
Well, let me ask you then, potentially an unfair question, Natalie, but what would a better solution look like, you think? What would, given that there are, to me, this is just what the problems you're describing are sort of intrinsic to our screwy, private sector dominated, broken, excuse for a healthcare system, but given that that's the landscape for the moment, is there a better? Would there have been a better way to go at this? Acknowledging, I guess I should add, that it will help some people, but would there have been a better way to go at it, you think?
Yeah. So, as I'm sure that you and a lot of your audience will agree, I'm a fervent supporter of Medicare for All. I think that is ultimately the necessary intervention for this problem and so many others that we have within the healthcare system. But, I think that we can agree that that's not on the electoral horizon during this term. And so in terms of things that are possible now, I do think that a preferable intermittent solution, or I'm sorry, a preferable solution for right now, brain blip, would be if you did fully cap the price of insulin, the list price of insulin. That would be, federal intervention to say the list price for this drug can be no more than $35. You could do that. There aren't precedents for this kind of thing, but public manufacture is still, an important idea that would be possible. I don't see why it wouldn't be. That's something that, Elizabeth Warren presented during the presidential primary. That's something that a lot of people have been discussing for a long time. And insulin would be a good candidate because there is not currently a well-priced generic alternative. There's also the possibility of just the federal government buying insulin and provisioning it for free for people who use it. Now, options 2 and 3, public manufacture, public manufacture, list price capping, or public provision, I strongly suspect that the reason that none of those things are part of the discussion is because they do set a precedent. They are big moves that would make a lot of difference. And if you do them surgically for one drug at a time, it will naturally beg the question, well, hey, wait a minute, why not for other drugs? And I mean, the way I see it, that would be a great question to ask.
Right.
So be it. That's a precedent that I would love to set. I think it's important. And that, insulin, like I said, I do think that there are some specific issues faced by people who use short-acting insulin that aren't necessarily faced by other patients. But, overall, that just means that they make the problems in the healthcare system very obvious. And that someone who rations, say, blood pressure medication for a period of many years could also face very dire health problems. They just won't be as immediate and as obvious and as easily ascribable to one cause in the same way. But ultimately, the effect is going to be the same for a lot of us. So, in terms of what we can do about insulin right now, especially given how much political support there is for doing something about the insulin pricing crisis, capping list prices is something that lawmakers could do. Public manufacture could be done, or public provisioning. There are only about 7 million short-acting insulin users, I believe, in the United States right now. So we're not talking about a lot of money when it comes to the federal government.
And it seems to me that insulin is kind of a perfect test case, or exhibit A, for what we should be doing, in that, number one, if I recall my figures correctly, you can obtain a vial of insulin in other countries for $8 versus $300 here. That's totally artificially created by government policy. It's not even, and again, correct me if I'm wrong, Natalie, but not even copyrighted the same way that others are, which is why there are multiple manufacturers. But the history of insulin pricing is that they all seemed to rise in lockstep, eerily so, almost as if there was illegal market collusion taking place. And there really logically is no reason not to either government manufacture it, cap the price, do all the things you just described. Is there?
I'm sorry. Is there
a reason not to? Yeah, I'm sorry. Is there a reason not? Well, one, did I summarize it correctly? And two, is there a reason not to take some or all of the steps you just described?
No, I mean, I don't think so. I think coming from the point of view of, why are lawmakers not taking these steps? I think the answer is because it is a big precedent, and they think that would compel, big federal action on other drugs. And what I'm saying is I think that that's probably right, and that's a good thing.
Yeah, no, I totally agree with you. And somehow it seems to me that moves like this are popular but not well understood by the public. It's complicated. Healthcare policy is complicated. It's tricky. It's got a lot of ins and outs, from patent law to market forces to everything else, the way we do it in this country. But it seems to me that this is, as you say, it's something that would be very popular, but politicians don't pay a price for not doing it. And do they? I mean, because no politicians are advocating for more forceful action. I'm working up to a question here, which is the Democratic proposal kind of the best we can expect for now, while people like us who believe in Medicare for all and measures like that keep working at it? A weirdly phrased question, and I'm sorry about that. But if you can make any sense of my ramble and can respond, would be much appreciated.
Well, yes. So I think that it is important to acknowledge that while the Democrats have a technical razor thin majority, part of the reason that this bill has been so chewed up from some of its first drafts is because there are several moderate members who are very committed to centrism, to budget balancing, who get a lot of pharmaceutical lobbying money, who are very aligned with business interests, things like that. So I think that, legislatively, a price cap, or I'm sorry, a copay cap is potentially the best we can expect right now. And as I mentioned, we don't technically know if it will make it through the Senate version of the Build Back Better bill. That's knock on wood. We're hoping that it does pass. And the list price cap. I believe that would have to be done legislatively. These are the kinds of things that, to actually know how these could be accomplished takes a little bit of legal knowledge. Manufacture, I'm not sure if that would be required I don't know if you'd have to put that through the legislature or if that would necessarily have opposition. I mean, I think it could potentially be something that gets support from certain quarters. We'd have to see. It's not really something that's been widely discussed. That said, not necessarily on insulin, because part of the dynamic is that insulin is not patented. So our tools for busting patents don't apply to short-acting insulin. But there are many executive actions that could be taken to lower the price of other drugs.
You're thinking, I'm sorry to interrupt, but you're thinking, for example, the Bayh-Dole law, which gives what they call march-in rights, where if the public good is threatened, the executive branch can take action to manufacture a drug and compensate the patent holder at what it considers a fair rate, that kind of thing.
Yes, exactly. Yeah. So march-in rights through the Bayh-Dole, or the even more broadly defined 1498 in the federal code, also allows the government to break patents and license drugs under certain circumstances. So those would both be things that I would encourage the government to look into and use. It really has never used them for drugs, and it should. That would apply to patented drugs. And, then maybe there's more money freed up for doing more for insulin.
And astonishingly, even in the midst of a pandemic, we've done the opposite, in the sense that, for example, the Moderna vaccine, largely produced, if I recall correctly, with public money, we turned around and gave the patent to a private corporation that is, in some cases, disregarding the public good in its handling. So it's an upside down world, it seems to me. But Natalie, Shure, since I just brought up the pandemic, you wrote another piece that I wanted to bring up because I thought it was really important, and because I held this opinion very strongly, and then you wrote about it, which confirmed in my mind your sagacity in holding a position, which I also hold. The headline was, "Here's a terrible new idea, making the unvaccinated pay higher insurance premiums." And this is because a lot of people, I'll tell you my initial reaction when this idea first came up was, it's felt to me punitive about a decision people were making that I don't personally agree with, but as you mentioned in yet another piece, had to do with a lot of other things other than just merely views we might consider misguided or crackpot, A. B, I don't think we should be using employer financing or any kind of healthcare financing to punish ideas we think are bad. And I think you had probably some more thought out reasons in your piece. than I did, but basically you open a Pandora's box. Well, okay, you're not getting the vaccine means higher premiums, smoking means higher premiums, not exercising means higher premiums, and all of a sudden you've got to kind of you're just crushing workers even more. What do you think? How do my ideas align with yours?
Yeah, I think that's exactly right. And it's interesting, that you brought up the smoking, because that was a provision in the Affordable Care Act that insurers could charge smokers more. And it didn't make people quit smoking. It just made fewer people get covered. And so, having fewer insured people, having fewer people with access to primary care, one of the only people that might be able to convince someone to get vaccinated if they're not vaccinated, strikes me as very misguided. So I don't even think that the plan would work, for one thing. And you're right that as much as I absolutely want everyone to get vaccinated, and I do support other types of mandates depending on specifics, I don't support any sort of, punishment through the healthcare system against what I would describe as health behaviors. I think that the fight against individualizing responsibility for health has been, something that advocates have fought to end and have fought to remove from our system for a very long time. I think people forget that before the ACA, if you were extremely sick, if you were a smoker, if you were someone likely to have higher healthcare costs, they could basically decide not to sell you a plan at all, or they could make it astronomically expensive. And protections for people with pre-existing conditions basically disallowed that. So protections for people with pre-existing conditions, it wasn't just a treatise that said, thou must accept, it did. They had to accept people with pre-existing conditions, but specifically, they could only change prices for premiums based on, location or age. So that meant that people with pre-existing conditions were protected. And so I think that charging people more based on vaccination status absolutely undermines some of the most important protections in the Affordable Care Act. And it's completely absurd watching people act enthusiastic about a plan that would do that. Because if you think it's going to stop at, whether or not you're vaccinated, I think you're crazy. I think that there will absolutely be people who will take advantage of it every step they can.
Exactly. And may I make two more points, mini rants and ads for your reaction to. One, it also strikes me as the kind of worst character attribute of, may I say it, a certain kind of Democrat who, the sort of prototypical, as they say, PME professional or PMC professional managerial class, who wants to punish people for behaving differently. I don't think that's politically or morally sound behavior, number one. And number two, I don't know how it is now, but when I was a health data analyst many years ago, the biggest determinant of an employee's potential cost was if they were a woman of childbearing age, because maternity costs are significant. So the logical endpoint for this kind of thinking is a kind of Handmaid's Tale of healthcare, where you would penalize women unless they were taking contraceptives for a personal lifestyle that potentially, it sounds extreme, but if you go down the road, it seems to me of this road, you're going to go places nobody wants to go. And your thoughts? I don't know.
Yeah, I think both of those points are absolutely correct. I think that, the whole history of policies attempting to nudge people into being better consumers of healthcare, I think that they've all been a failure. I think that they're all neoliberal tripe. I think that we have to get away from all of them. I think we need just universal care, free at the point of use for people who need it. And whether you need it because you made the right choice or not, I don't care. I think that we should legislate away anyone's ability to care or anyone's ability to whack someone on the head if they care. I hate it. I hate all of it. And I think that your other point about women is absolutely true and important. I think that people don't realize the extent to which healthcare for all, Medicare for all, universal healthcare is a feminist issue. Not only are many women dependent on spouses for healthcare, which, people talk about job locking you into a job that you might not want because of healthcare. And that's true, but it could also lock you into a relationship you don't want. A lot of women each year get divorced and lose their insurance. Obviously, women make less money than men, especially if they, have care roles, caring for parents, for children. Then, that time that they spend doing that is likely unpaid. They make even less. And so being able to afford and access healthcare is difficult. And then there's also the issue that, yes, for non-elderly adults, women use more healthcare than men, and that's largely owing to cis women, our reproductive systems, reproductive care. If you are a healthy man versus a healthy woman, a healthy man is pretty unlikely to use very much healthcare until he's already on Medicare. A healthy woman statistically is very likely to use a lot of healthcare before she's on Medicare. Statistically, women who are of childbearing age are very likely to have at least one kid. That is going to cost a lot, take a lot of time, require a lot. There are a lot of states that, have Medicaid coverage for, a period before and after childbirth, but Medicaid cuts off pretty low depending on what state you're in. So it's certainly not something that's universal. And depending on your deductible situation, depending on your networks, I think that there aren't too many people who are able to get out of paying immense amounts out of pocket for what's already a very stressful stage of life for a lot of people. Stressful and exciting, but certainly not the time in your life that you want to be paying out of pocket exorbitantly for healthcare to make sure that you are able to keep yourself and your family healthy. So it's absolutely a gendered issue. And I think that, the fact that men do use a lot less healthcare until they get older, until they're already on governmental healthcare, certainly confers some insight on why we're still where we're at in this debate after decades and decades.
Exactly. It's a gendered issue and it's a disability issue too. So, people with disabilities are, so, and lastly, I guess I would point out one of your articles describes how many people are unvaccinated because our healthcare system is filled with hidden costs and traps. And, while the vaccine is supposed to be free, they're reluctant to go in, right? And they are fearful, understandably fearful of our system. Am I summarizing your article reasonably accurately?
Yeah, so that was based on polling that was done several months ago that a pretty significant amount of still unvaccinated people expressed skepticism that the vaccine could really be free. And still had fears about cost. And I think that what that reflects is that even though the government did step in and make vaccines fully free, which was important, and I'm glad that they did that, and it is illegal for someone to be charged in any way for a vaccine or be asked for immigration status, to be asked for, insurance papers, et cetera. That didn't always pan out. Sometimes people did still get erroneous bills, things like that. But for the most part, they are free. And as good as that was, I think it does say a lot about our healthcare system and the relationship that people have developed with it and the trust that people have in it, that there was a significant cohort of people who simply did not believe it was free.
Well, Natalie, sure, there's so much else we could talk about the healthcare system. But for now, I'll just encourage people to find your writing on the New Republic and elsewhere. And for people who are listening on the radio, it's Natalie, Shure. And so check her writing out. It's very important. And Natalie, good to talk to you. And as always, thanks for coming on the program.
Thank you so much, RJ. I appreciate it.
And we'll be right back after this. I am Richard RJ Eskow, and this is The Zero Hour.